it is imperative that we cut down the 17-year gap in translation. I mean, people need these treatments now. And what's fascinating to me is that even though we talk about wanting to really ground and anchor in the science, which I do believe in, the science that we have, even when we go through 4 or 5 RCTs, in and of itself is already incomplete because it's missing key voices, key experiences,
Right.
and key scope of humanity, right? So we have to include more of the community, more of the patient population, and how we understand those data in general.
Is measurement-based care a critical tool for improving equity in mental health care? In this episode of Neural Compass, Innovative Care Models to Improve Health Equity, Yale psychologist and professor Amber Childs explains how her work has shown the value of measurement-based care. We also go deep on the opportunities for AI and other technical innovations to improve outcomes and reduce access disparities, and her own journey as an entrepreneurial clinician scientist. I love this conversation, and hope you will too. Welcome to Season 1 of Neural Compass, where we explore the future of mental and behavioral health at the intersection of clinical care and cutting-edge AI. I am your host, Mark Jacobstein, co-founder and president of Jiminy Health, and I am really excited to be here today with Dr. Amber Childs, who is a psychologist and professor of psychiatry at Yale. Dr. Childs specializes in youth and young adult mental health, digital innovation, and data-driven care transformation. We're going to talk a lot about data-driven in the course of this conversation. In addition to her research, she's done really important work in measurement-based care, which we will also hopefully discuss, and helped launch the GROW, which is Getting Racism Out of Work initiative at Yale, which we're also going to touch on today. So thank you so much for being here.
Oh, of course, Mark. I'm so pleased. And, when I met Louis at the panel that we did together at School of Management, they had the Yale Healthcare Conference. I knew for sure that really important work was happening with your team and just wanted to be in good conversation with folks who are really thoughtful in this space. So I'm happy to join. Thanks so much for the invite.
Fantastic. Well, thanks for being here. So let's jump in. I want to talk about MBCs, or measurement-based care, which is I think a pretty hot topic right now in the field of mental and behavioral health. So maybe I'll start by, for our listeners who aren't familiar, talk us through, so what are MBCs, why do they matter, and what has some of your research shown?
Okay. I love talking about measurement-based care. I'm sort of like the measurement-based care aficionado at this point in time. So let me tell you like a quick story. Back in 2017, I was pregnant with my first child, and I remember at that time I had just sort of rounded the corner on my second year as the lead psychologist in the adolescent intensive outpatient services at Yale New Haven Psychiatric Hospital. And when I was brought into the service line, I was brought in because they were really hoping to develop new behavioral health programs to help capture a different audience or a different group of consumers that they had not previously been able to capture within their sort of overall portfolio. And so I came in with this radical idea at the time, which was, what do we understand about the population that we're actually trying to serve? And what are the that speak to our understanding of that population? And yet let's use that to help us build out the service line, as opposed to only thinking about some of the, and maybe this isn't a fair assessment, but instead of sort of overly weighting the business and revenue objectives that we want to obtain. But how do we do both of those things? So
Sure.
I was sort of bringing in this notion of how do we do data-driven programming, and then as a function of that, data-driven care. So I was doing a lot of that work for the first 2 years of really trying to understand who folks were, really implementing some data-oriented processes of, how can, in youth populations, we need to understand things both from the youth perspective, but also from the caregiver perspective, because they're a key member of that ecosystem. And sort of how can we bring both of those two data points together to help us really get a good, clear understanding of what's happening for kids and teenagers. So I was already sort of tilling the soil around data-based care. So cut to 2017, I go away, I have my baby, I come back. January of 2018, the Joint Commission says, okay, everybody, guess what? We are requiring that people use measurement-based care, which is this data-driven process that we're going to use to begin to adjust meaningfully the course of someone's treatment over time. And, imagine me, I'm sitting here thinking like, oh my gosh, this is sort of what I've been saying. How do we use these data to inform what we're actually doing? So it was great news, I think, from a data standpoint. But at the same time, there wasn't any sort of implementation guidance to support that. So I'll talk about that in a second. So let me tell you what measurement-based care actually is. Measurement-based care is this practice of routinely and systematically collecting data about what the patient says is happening in their experience, and then getting curious together as the patient and the provider in the context of your care relationship about what those data mean, and then how you can use those data in very strategic ways to adjust the course of that person's care over time.
So what's a good example of the sort of data that you're extracting, and then how might that modify somebody's care plan?
Traditionally, what it looks like in a straight ahead way is I'm going to, work with a person on reducing, for example, symptoms of depression. And this is a very sort of reductive example because that's not exactly what people are coming into care to do. People have a sort of full scope of humanity. But I'm going to reduce symptoms of depression. So I'm going to use a standardized assessment tool, and we're going to establish a cadence on how often we're going to assess your symptoms of depression. Then we're going to get curious about what's happening sort of proximally, like what happened in the weekend before you filled this out, and how can we stack up these assessments over time to try to look at a trajectory and pattern. So we notice, gosh, every fall, I'm noticing that there's this really big increase in your symptoms of depression, and it starts to go down. Let's get curious about that and what might we need to think about. Or I'm noticing that your overall symptoms of depression are decreasing, but we see this longstanding challenge with sleep or maybe some other cognitive aspect of your experience. Do we want to make an in-session tweak to that particular element so that we can target that more fully? So that might be what we would do. And I think there's some creative ways that we're hoping to bring in data and assessment beyond that sort of standardized symptom report that would allow us to have more of a 360 view about what's happening.
This feels so important to me. And I will tell you, just to bring in my own personal experience, I've always been shocked. So, 25, 30 years of therapy with 4 or 5 different therapists on 2 different coasts. Personally, I have never had a therapist do a formalized assessment that would allow them to measure GAD-7 or PHQ-9 scores or other measurements of anxiety, depression, things that maybe they've been working to alleviate. And I've always been fascinated by this because it's hard to know, to move past sort of the subjective. And I do think that they would do a better job sort of informing care with me in something like this. And I think about other parts of medicine. It's surprising it sort of happens so late in psychology and psychiatry, I think. But I'm very happy to see the measurement-based revolution occurring. And in your own sort of practical experience as a therapist, do you feel like it changes the trajectory of the therapy often with your patients?
If we're doing it the way we're supposed to, it absolutely should, in some positive ways. So I think the keystone things that we see is, as we all know, and I think that we've seen repeatedly throughout sort of empirical science around behavioral health treatment, is that the therapeutic alliance and relationship really is a strong predictor of overall outcomes.
Right.
And because measurement-based care is this standardized practice that really fosters shared decision-making, there's a lot more of an opportunity, we think, mechanistically, to really enhance that therapeutic alliance. So, a lot of times in populations of color, for example, one of the primary challenges in these sort of differential outcomes that we see for folks is patients of color saying things like, well, I'm just not on the same page with my provider. Right. I agree with the treatment course that we're having, or they're not hearing my concerns, or there are challenges sort of writ large around the alliance. And so might this be a tool to sort of bring us together so that we have something we can lay out in front of us that gives us at least some data markers to then begin to examine and improve alliance. So that would be, I think, the big element in my own mind. Then, clinicians, we want things to be good. This work is really hard. And we want to see the best in our patients, and we want to see the best in ourselves. But clinicians are really not great predictors of their patients' overall treatment trajectory. We're not great predictors, unfortunately, of deterioration that might be happening in our patients. And so the other sort of benefit of using this measurement practice is that it allows us to be better able to detect when treatment is not on track so that we can intervene appropriately.
I love that. I mean, one of the things I think a lot about is what it's like to actually be a human therapist. So I have a sister who's an LCSW, lives in Hyde Park, Chicago, has worked most of her career on the south side of Chicago, working with a variety of different populations from, really disadvantaged youth on the south side to neurotic undergrads at the University of Chicago and everything in between. And one of the things I always think about in terms of the job is you have to be present. You're listening, you're thinking about the appropriate therapeutic modality. Are we working on restructuring, reframing? How do I respond to this? I got to remember all these things about a patient. It's a very, very sort of multitasky problem that involves also being extremely present. It feels very hard to me to in the moment to also be doing a great job of assessing. And so having some sort of structure where you're more formally extracting data and then doing an analysis strikes me as an incredibly useful tool to, okay, so now I can actually measure these things. The other thing I think worth noting is you'd mentioned sort of the economic issues in healthcare. I fortunately spend some of my time talking with payers and how they think about behavioral mental health. And one of the challenges that they have with behavioral mental health is that if you're not practicing measurements-based care, often they don't really understand, they don't know how effective a given therapist is, a given therapy is, the particular treatment plan for a patient. Somebody's been on therapy for years. Is that because they really need it or because actually they're fine and they're still paying for it? And so there's all sorts of exogenous factors too that I think would be people throughout the ecosystem ought to be excited about measurement-based care. And so one of the things I'm curious about is, do you get a lot of pushback from anyone, from whether it's therapeutic, from the therapist, from the patients, from the payers, anybody sort of involved in the care journey, or is this something that sort of universally people are excited to pull through?
Oh, Mark, I think there's a lot of different, I think there are really complicated feelings about measurement-based care. You know, on the one hand, people believe and understand that with measurement-based care, people get better faster, they drop out of treatment less, and they improve more. And there's a lot of clinicians who are down for that revolution. I meet very few clinicians who are like, I'm not above using anything that I can to help my patients. Right. And at the same time, the way that measurement-based care practices have been implemented has really struggled in that regard. So there's a lot of challenges from an implementation standpoint that really, I think, damper the enthusiasm. And I think one of the key ones beyond, let's say you get a really great measurement feedback system, you really have an integrated sort of EHR interoperable system, there's really low friction for the patient. It even spins up for you some things that you can put in your documentation. And let's say that piece is taken care of. The Joint Commission puts this other standard of like, you have to also now use these data in aggregate to understand something about the performance of your overall program. A lot of clinicians then say to me, well, it sounds like maybe the next step of that is we're going to assess individual clinicians' performance. Right. And then that's going to have some bearing on I'm
going to get fired. I'm going to get demoted. Right.
Yeah.
Right.
Or I'm going to begin to inadvertently or maybe sort of conscientiously adjust my caseload because I'm concerned that patients who are at higher levels of acuity where the treatment would have them maintain their symptomatology is going to really disadvantage me because I need to showcase that there's a decrease in these symptoms over the course of the tool. So I think there's complications in terms of how people are actually leveraging the practice that make it hard for folks, And I will just say it's a sort of generous assessment that we've really worked out the clinical workflow and implementation challenges. So I think, again, there's a lot of work and progress that's happening in that regard. On the patient side of things, I think there's a lot of opportunity. If we can get clinicians to figure out these sort of implementation challenges and if we can help clinicians understand this as a tool to also demonstrate the value of the care that they're providing, which I think is what you were getting at before. There's also some psychoeducation that needs to happen for patients to understand that this is an empowerment tool for them and how might they best really leverage this. So I think that hopefully as we address those things in the progression of the practice, we'll begin to smooth out some of those issues. We also got to figure out what we're calling it. So there's a big, huge beef about, is it measurement informed care or is it informed care that includes measurement, and what goes first, the relationship or the measurement? So,
MBC isn't really catchy, I will say.
It needs some marketing or some branding minds around it.
Yeah. It's so fascinating. Well, so one of the things I think about, you mentioned sort of the resistance of figuring out the workflow for all this. And one of the other things we spend a lot of time thinking about, Jiminy, is that if you're lucky, a therapist has 1 hour a week, typically maybe more like 45 minutes once a week with a patient. And there's a lot to get done in that time. And so if some of that is consumed with a new workflow, that is just that much less time for me to do any of the other things that I was hoping to take on during that time. Establishment of therapeutic alliance, figuring out what I should be doing with your care, figuring out what's happening in your life. So I'm curious if you've thought much about sort of external tools to help with this, and specifically thinking about AI-based tools that can sort of supplement the work that a therapist is doing and then inform them. And if this is something you're seeing adopted in any way in the clinic just yet.
Well, actually, maybe I might even take like a step back to answer your question and say, the question that you just asked is sort of the inflection point for me of how I started ImSelect, which also needs a marketing and branding person to support its name. It has a terrible name. I came up with this name in the middle of the night. My daughter had COVID for the first time, and I had like 2 days to apply for this innovation award that was happening through Yale New Haven Health System. It was like their inaugural awards. And the reason it was, it stands for Measurement, Selection, and Education Tool. Okay. Terrible name, right? But it started because it was really in response to this need to be able to support clinicians in actually engaging in the clinical process of MBC and really helping to fall away all of these other administrative and workflow challenges. And the biggest one that I found in my, what I will now call customer research at the time, was clinicians were concerned that they needed to become psychometricians in order to use this practice effectively. So I need to know every measure, how to use it, and understand all these different dynamics of what meaningful change means on the measure. And then I'm trying to maintain an alliance. And I've also got Epic open and I'm clicking through 100 things, and it's a virtual.
And no one told me there was going to be math on this test. That's not why I signed up to be a psychologist.
So math is not mathing. So I said, okay, you actually don't need to be a psychometrician. I want to create a solution that's going to allow you to be the clinician and to do all of the things that you do incredibly well, and to give you back time in the session, but you still get to leverage this practice. So what the solution started as was a tool that was going to help providers algorithmically make a decision about what measure was the best fit for the right patient and the right symptoms. And then it was going to provide them with sort of clinical decision-making support about how to use that measure in the session and take away the guesswork to really support them. It was also supposed to be interoperable with the EHR so that it would sort of smooth that.
Wow, you really were ambitious.
Mark, let me tell you what.
Apparently, you'd done no work before this trying to integrate software with traditional EHRs.
It was a fever dream or something I had, that because we were using also Epic, and as you know, the majority of the country is using in health systems, and so I was like, oh yeah, this is 100% possible. It's going to include like a companion app. We're going to get this in the app orchard for Epic, and then it's going to pipe these into Notes. The reason I believed that this was possible is because I had fashioned a similar, kind of like a Wizard of Oz type solution within the Epic native platform itself. And actually, if you go into my chart now in Yale New Haven Health System, you can see what are called behavioral health trends, and you can see the measures plotted out. So I thought this was possible. I thought this was 100% possible. And what I realized was that providers and clinicians almost need like a change process doula to help them implement these different practices. You know, like even if it's going to help them, and even if it's going to smooth out workflow challenges and let them just go into sessions and be the clinician, it requires so much provider behavior change.
You know, it's funny because I've spent my entire career in sort of technology entrepreneurship and building software tools throughout a variety of ecosystems. And I only moved into healthcare maybe 10, 12 years ago. I started with a molecular diagnostics company. Now I've worked in therapeutics and now time at Jiminy. One of the things that's really interesting to me is changing behavior in healthcare is the hardest place to change behavior that I've ever seen. And there's really good reasons for it. So like status quo bias is a normal human thing, but clinicians have been trained with status quo bias, right? Whether it's first do no harm, deeply scientific, typically a personality that is one that like clinicians are not cowboys, or they never would have made it through medical school or through a 5 or 7 year, psychology PhD program, et cetera. And so this intersection of sort of personality type, the training is be very, very careful. We don't change things until we see an RCT and we read the methods. And it was from, an August journal and great KOLs. And even still, I want to see 3 papers that back it up. Mm-hmm. That's when I might start to change behavior. We've seen 17 years to change patterns of behavior in medicine is pretty typical. And I can imagine mental behavioral health, which is often historically anyways, a little less data-driven than, say, oncology, where you look at some Kaplan-Meier curves. It's probably even harder. So I'm curious, maybe one thing to pull this through at a place like Yale, but how you think about implementing your doula. I love this idea, your doula for sort of practice change, and specifically how you do that in the community, not just at a place like Yale and what you've seen so far.
I think you've actually just identified what I found out was maybe the key. So I was really going after this from the framework of how do I support providers in their ability to implement this practice? And then I realized this has never been just about a provider-driven practice. Inherent to the practice is shared decision-making, collaboration, working together. This has to actually live, or might it be able to live with the patient or with the community? How might we let this be patient-led in a way that enables the provider to come alongside, right? And then we give them the tools to make that helpful. So the second iteration of that solution actually became okay, whoa. This isn't just something that's going to help providers do unto patients this practice. This is going to be something that empowers patients to be able to leverage their own data on behalf of themselves and then connect them, the provider, and, I'm a youth person, and the caregiver, so that all of these key players in this ecosystem are now benefiting from these data. And then what provider is going to be okay, here's this data that helps you understand more about your patient and their experience, and they are actually taking these assessments and want to talk to you about it. What provider's gonna be no, I'm not gonna be discussing that with you, right?
That's fascinating. I love the notion of patient pull. We're seeing it more and more in different parts of the healthcare ecosystem. And it feels like also embedded in there is the magic of a good workflow versus a bad workflow. Mm-hmm. This needs to be probably very easy for both the patient and their caregiver and for the therapist to actually work with. Otherwise, no bueno. So where is the program now?
So oh my gosh, it went through 1,000 iterations. My naivete was very quickly pulled into check when I realized that in fact, interoperability is something that's going to happen in 30 years from now. Maybe not, but certainly within the academic medical center context was not something that was going to be happening at 1.75 speed. And to your earlier points, it is imperative that we cut down the 17-year gap in translation. I mean, people need these treatments now. And what's fascinating to me is that even though we talk about wanting to really ground and anchor in the science, which I do believe in, the science that we have, even when we go through 4 or 5 RCTs, in and of itself is already incomplete because it's missing key voices, key experiences, right, and key scope of humanity, right? So we have to include more of the community, more of the patient population, and how we understand those data in general. So the product itself iterated to become that tripartite solution, which was going to be sort of youth-oriented, mobile-first video, self-guided, evidence-based treatments that used measurement-based care, routinely assessed teens and sort of algorithmically changed the treatment that was being provided, and then use those data to provide curated strategies and insights to caregivers in a separate portal. And then finally would provide clinicians with clinical decision-making support and sort of summary guidance of what those data were from the patient. I was able to secure some different accelerator awards and develop an MVP for the product. And there was a company that licensed the intellectual property briefly for that work so that they could really help that advise the clinical aspect of their solution. They had a really great patient-facing solution at the time. We wrapped up some work at the very end of December in 2024 and just related to how that business was moving and shifting. We didn't have the opportunity to build those components out further, but really the ideology of making sure that data is working hard on behalf of patients but that's also advising clinicians and key stakeholders is still very much alive. And I'm looking for places to continue to plug and play those.
Well, first of all, amazing work. I am always struck by the similarities between what it means to be a good sort of clinician scientist and what it means to be a good entrepreneur. My wife is a physician scientist, and I see sort of what's the happenings in the lab, and it's sort of rapid iteration on hypotheses, right? It's hypothesis, experiment, result, new hypothesis again and again until you find the answer. And similarly, a lot of this comes down to sort of like velocity. There's always a touch of luck, of course, but like velocity of learnings and willingness to see what the experiment is actually telling you as opposed to what you wanted it to tell you. And that's where sort of the magic happens, whether it's creating a new digital product or thinking about a new therapeutic modality. It feels very similar when I hear the descriptors. The big difference, of course, is I guess when you work in healthcare and you're actually taking care of patients is certainly there's no move fast and break things, right? These are real human beings who are involved in the care, and that means a whole extra layer of being careful. A lot of the work that you've been doing is in an adolescent care setting, which strikes me. I have a 9-year-old who's a tween, and soon we'll have an adolescent at home, and very excited for that challenge, but also appreciate that it's a tough time. And you mentioned also, for sure, as a result, there's at least one and often multiple caregivers who are involved in influencing their lives. I also think, of course, with adolescents, the peers have such an incredible 100%. Influence. How do you think about that in an MBC context? How do you think about all the other sort of exogenous factors? This is not just like me telling you how I'm feeling this week. There's a lot more to it.
So are you asking more in terms of like the multi-informant report that is probably needed to better understand?
How do you actually like sort of literally sort of what's the product experience is the way a product person would say it. And so how do you get the caregiver involved? And you'd mentioned even with the adolescents that you built mobile applications, sort of I always think of this like bringing the medicine to the patient where they are, right? And everybody's got a mobile phone. They engage with their mobile phone. This is a great way to do it. But sort of how do you think about that for say the caregiver? They're probably not sitting in the session necessarily with the therapist.
Yeah. I would say this to you as a provider in our intensive outpatient program, for example. I've worked in so many different settings. And actually, maybe this goes across these settings. Invariably, I would spend almost equal parts time with a caregiver, either by phone or in family sessions, really exploring and reinforcing the work that was happening with the youth in particular. So I know there are a couple of different camps of how you might do work with a teen. And one is, we want to focus only on the teenager. And there are a lot of concerns, rightly, around privacy and confidentiality. The reality is that teenagers do not exist in a silo. I think you've pointed this out rightly, that there is a really broad, actually none of us do, to be honest with you,
sure.
But there's a really broad and I think proximal context to what it means to be a youth. Like you probably still live in a caregiver's home, right?
It was just a big article in the New York Times last week about the importance of siblings, which we all know. Yeah.
People are like in your actual immediate space in some way. You're not just like calling up once a quarter to, say Happy Mother's Day or whatever it might be.
Right.
So I think that there is necessarily a kind of inclusion that has to happen, and that would behoove us, right? I mean, a lot of the literature that we have says that when you can include caregivers in a treatment process, teenagers are actually, I struggle with the word adherent because it seems very forceful, but teenagers are actually more participatory in their treatment.
Better than compliant.
Yeah. They stay the course, right? They stay the course in their treatment. They move through the work and they actually demonstrate better outcomes when there are caregivers involved. Now, there are absolutely caregivers who are not able to meet the teenagers where they are, have like differences in values and differences in their ability to really honor and respect what might be happening there. But to the extent that we can include caregivers and be mindful of those privacy concerns, I think is critical. So operationally, what that looks like is how do we sort of provide caregivers and how do we automate some of the psychoeducation that they might need and benefit from? But how do we curate that in a way that they're not just going to the American Academy of Pediatrics website and being like, how do I help my teenager, right? So how do we use data to help them understand, okay, here are the things that might be more targeted for your specific youth. Here are questions that you might want to ask. Here are different strategies to reinforce what they might be experiencing. We're not going to send you off kind of on a wild goose chase. And I think about kind of the parallels of how teenagers and caregivers use communication methods now. And I'm like, why can't we replicate that in the behavioral health space? For example, a lot of teenagers in treatment will say things like, all right, the way that I promise this is more than just like a one-off thing. I wanted to talk to my mom about using my correct pronouns, like respecting my pronouns. But I needed to first come out to my mom that like, I'm using different pronouns than the ones that you've been using for me, right? Yeah. So what I did was, I'm a teenager, what I did was I sent her in Instagram a video of another teenager talking to their parent about using pronouns, or a video of somebody explaining how they came out to their parents. I text that to my mom, or I send them a TikTok video that I saw doing this. I cannot tell you how many times teenagers have said that they're leveraging technology to try to sort of front load these conversations or give themselves language for something that they hadn't understood. Now we got to be monitoring that content and making sure it's like on point.
Right. Yeah.
But I was like, why don't we use a solution that actually has evidence-based content, actually has strategies, and a teenager can say like, I would like to push this to my parent to say like,
this is TikTok for good. Yeah.
Here's how we can talk about this.
That's so powerful. And I love the sort of, frankly, the adolescents figuring out the solution to the problem is very exciting. One of the things that sort of implicit in what you're saying is, if you think about sort of data-driven technology personalization, what that immediately says to me is some form of AI. Now, there's some of this isn't really AI. It's like have a catalog of content that a patient, an adolescent can choose from in order to help with their conversations with their caregiver. It doesn't require any AI, but I think there are more advanced versions of this that do. And one of the things, and I know you spend a lot of time thinking about sort of providing, mental health solutions in communities of color. And one of the things that we all know has been a problem with AI is sort of the alignment problem. And AIs having been trained up on data that are intrinsically and historically biased. And then that gets manifested in the AIs. And hopefully we're making progress on the problem, but it's a problem for sure. Has this been a sort of area of work for you as well, or sort of too abstracted away from the sort of the day-to-day of your programs?
I think it's more abstracted from the day-to-day, but from a theoretical standpoint, I've thought about this as like, isn't this... Absolutely, there are all these pitfalls that we need to consider. And Dr. Shirley Wang, who is at Yale now, she's an assistant professor in the university side in psychology. She and her lab talk about this quite a bit. But I think, and we got to interrogate all of the data that we have and how it's sort of intrinsically biased, as you mentioned. But I always think, isn't this the great opportunity that we have now? If we're building it, how do we build it in a way that we start these protocols off in a way that accounts for those biases based on what we can understand now, which in 10 years we should look back on and be like, oh my gosh, I can't believe we thought that was the right remedy. Right. And that would mean we were still making progress. But isn't this the opportunity to actually disrupt that? So for example, with cognitive behavioral therapy, it is old news at this point, right? That like this was not tested on representative populations. It is still the gold standard of care and treatment, right? Interpersonal therapy, cognitive behavioral therapy for depression. That doesn't mean we're not using it, but what people have done is they've sort of iterated on that main block of what the treatment is. I think that AI enabled work and sort of where we're moving now is an opportunity to actually build a different like foundation, right? Instead of saying, let's use the current foundation that we have. And like, then we'll be like, okay, this is CBT for, African-American populations. This is CBT for LGBT people. It's like, what if we're actually making an entirely
new paradigm?
Yeah, exactly. Yeah. Exactly.
Yeah. Well, we spent a lot of time thinking about that at Jiminy because while CBT has helped tens of millions of people and is effective, it was, in addition to all the other constraints, all the other challenges, like it was only tested on a certain population, et cetera, it also worked within the confines of the way therapy could work in a world sort of pre-technology world, right? Where at best, I saw you once a week for an hour. Those were the tools. And maybe I sent you home with a piece of paper to do some exercises. And so one of the things we spend a lot of time thinking, like, what is the future of therapy? Like if therapy is helping people live better lives with words, right? I'm curing you with words. What are the best ways to do that? And that may be much more multimodal than just a therapeutic session, and related to some of the earlier conversation, working with your caregivers and other parts of your life and assigning you exercises and all the rest of it. And should that be CBT influenced? Probably, because CBT is proved to be effective and important in a lot of different ways. But I love this idea of, like, can we rethink the whole thing, including having it be informed by the fact that the experience for an adolescent of color or LGBTQ youth might be different than someone who's not. And
yeah, in fact, it is. So let's build that in from the beginning based on the best science that we have available at the minute. Actually, I love what you just said about, sort of curative work through words. A really good colleague of mine often talks about psychotherapy as like the practice of free speech. It's like enabling freedom of speech. And in so doing, it's like enabling like freedom itself. So one of the things I think is so interesting about Gemini is that, to the extent that there's this like AI enabled tool, the tool isn't just like sort of operating on its own out there. It's actually operating instead with the patient and with the provider. And it will be able to sort of have information about the person that comes from the person themselves. It's almost like a self-study in a scalable way. And that, to me, I think is like the power of data, right? It's how do we actually scale these interventions? It's not within the system and sort of we build this in a system and then scale that learning from that system to other systems. It's how do we actually understand what's happening at the individual level and then scale that up across populations, right? So I love this notion of, the AI enabled components of this are driven by the patient and by the clinician. And it facilitates. You can
imagine, we're not there yet. I don't want to pretend that we are, but you can imagine versions of this in the future where the Gemini system, which includes your therapist and the AI, has a much fuller understanding of who you are because of access that you've given it to all sorts of things. I mean, your mobile phone is with you all the time. You can use it for journaling. That journaling, for example, can be therapeutically influenced. We're going to work on cognitive reframing, and because I do a lot of black and white thinking, or et cetera. And those things can all happen with your mobile device. That's part of why we called the company Gemini, right? It was like Jiminy Cricket with you all the time.
I was curious about that. Okay.
Yeah, we spelled it differently. So
I just went on a Disney cruise. So I'm very I was listening with an interested ear to that.
Yeah, that was part of the inspiration. So, so switching gears here, I wanted to talk about Grow, which is another program that you've helped to launch. By the way, you must be very busy. There's a lot of, you're not just involved with a lot of these programs. You seem to be co-founder and director of, and appreciate what that means for your busy life. But talk to me about Grow, getting racism out of work, where it sort of came from, how it's developed, and learnings from it so far.
Yeah, I'll just comment really quickly on that. Like, one of the reasons why I have become this sort of entrepreneur person, I think, is just related to sort of at baseline, my desire to really move things along with pace and sort of how can we establish processes around them. I didn't even know that was necessarily called like innovation and entrepreneurship until someone pointed that out to me a couple of years ago. And I was
Patience
like, wow,
is not a virtue for this sort of thing. It's good to be impatient. Yes.
100%. So the Getting Racism Out of Our Work initiative, I co-founded that with a couple of really phenomenal colleagues of mine. And it was the cornerstone project of my work as the director of training for the psychology doctoral internship program. And years ago, when I was a postdoc in training, I had the unfortunate and all too common experience that many Black people have of having a really racist supervisor. My supervisor would make comments and remarks that were just incredibly damaging about patients that I was treating. And there was quite a bit of sort of gaslighting around my ability to really call and detect this. And in fact, there was this part of me that really didn't want to believe that was what was happening because it was just so aversive. And so it was a damaging experience. I almost actually left the field of psychology at that time. I was 2 months away from graduating, and it was so painful that I was like, oh, I will literally give up these years of training to get away from this. So I pivoted to Yale. I didn't pivot to Yale. I got my first job at Yale. And I had this opportunity to kind of reset, and sort of over the course of time, I began to reconstitute and sort of have some restorative, reparative experiences. And when I became the training director, one of my key pieces of work was the Diversity, Equity, and Inclusion Committee. It had already been started years before, and we had culled all of this data about trainee experiences in supervision and in the program overall for the past 5 or 6 years before I was even the director. And I was like, what are we doing with these data? And now I can see some patterns here that let me know that we have an opportunity in terms of how supervision is unfolding. And our trainees are saying, like, I think there's some room here for our supervisors to become more racially and culturally responsive. And because clinicians are who ultimately go out and do the work, it was imperative to me that we were training clinicians in a climate that they were able to have their humanity and respected. And so because that would have implications for the clinical care that they provided. So I created this data-driven program that used these data based on training experiences to say, here are the key areas that our supervisors need help and support with. And what we found was that it wasn't just about providing our supervisors with foundational knowledge about, diversity or equity or, cultural frameworks. It was really helping them to understand themselves as the sort of supervisor and educator tool. What am I bringing to this? Because that gives rise to a much more expanded way of practicing in supervision and in the clinical work that they were leading.
So sort of a self-awareness piece.
Exactly, which is the hard and painful work, but it helps you to scale those learnings across all kinds of different things that you can't know and won't encounter until you encounter them in the future. So we created this program, we piloted it, we collected data, and then I realized, supervisors were like, oh my gosh, we need more of this. I did this on a $7,000 budget, Mark. It was wild. We trained like 45 supervisors. We got a wait list.
This is why you're a great entrepreneur.
Thank you. We got a wait. This was not a shoestring budget. I joke to people all the time. This was a flip-flop budget. So we got a wait list that we built, and then we trained over 100 psychology supervisors and psychiatry supervisors within the Yale ecosystem. We had a buyer from Northwestern University who purchased into the curriculum during its second pilot, where I continue to raise internally. And I realized people want to dedicate themselves to this learning, but they don't have the time to do this. But nobody wants to say they don't have time for diversity, right? Like that just doesn't sit right. So how can I develop this digitally enabled program that will allow supervisors to do this work? And so that therein is sort of how the GROW initiative was developed. I wanted to make sure it had broad reaching impact above and beyond its core product, which is the main training and program, to a digital program called Grow Seeds, which is still pending because I had a baby and I haven't fully launched that yet. But it does, training in entrepreneurship and innovation for trainees. There's an evaluation and research arm that's there. There's a scholarship arm that's there. And I realized like, oh, wow, I'm really good at raising investment dollars into this kind of an innovation, and I can bring stakeholders together around a really hard problem. So that's the GROW.
By the way, on that note, there's an old quote. I think it was Highland Capital Partners. This is literally from the 90s. Used to have a quote on the front of their website. This was an old August venture capital firm, which says, raising money is not a distraction from the CEO's job. It is the CEO's job. And I think about that actually a lot for the sort of healthcare, like clinician scientist version of that is the PI's job. It's basically, you want to make the thing happen. Part of it is wrangling the money, because ultimately what that is like having a vision and painting that vision. And that allows you to attract the right people and the dollars and all. And it's the only way to sort of manifest it. So first of all, kudos on making it happen. Last question on that. Current political climate has made working on initiatives like this difficult. DEI is particularly at an Ivy League university where there's an awful lot of probably unwelcome attention from the current administration. Have you had any challenges or pushback or anything else from as far as continuing the work on GROW?
Well, fortunately, Grow was seated in a department that really prioritizes this work and so has been unwavering. And I think at one point it was like, are we still doing this? And they're like, continue your work. We're still doing this. And that's a very specific context that I find myself in. But I'll just step back and say, there has never been a time where this work in particular hasn't been difficult. And so in my own mind and in the mind of a lot of, I'm sort of in the group chat with all the Black women psychologists and psychiatrists. We're like, yep, this is a new shade of kind of a very similar thing. And there's almost always a turning up of the temperature in these waves. And so how do we want to think about this now? How do we want to play this? What is the long game for this? But that said, it does have some real implications when we start to touch into places where there are federally funded, fellows and trainees, and sort of how do we want to scope this in a way that really protects their ability to train and our ability to get this work out. There was a time when, Mark, I literally, even when I was on child rearing leave, I would get an email a month of like, can you bring Grow to our company, our facility? We have money to pay for this. Right. Yeah. External to Yale. And some of those requests have dried up, right? Around, our hands are tied. We're not able to spend these dollars in the same way. So I would say that, I don't know that there's less of a demand for it, more so than there are some blockers to the traction that we were previously having. But I did just get an email from someone like, hey, we're trying to launch our diversity, equity, and inclusion committee within our internship program, which I think is such bravery, right? To say like, we're doing this anyway. We're doing this anyway. Can you come talk to us about how we can put this together, how we can establish our metrics, how we can do this in a way that's going to withstand the climate that we're in. Well,
but to your point, this has never been easy work, right? From, Henrietta Lacks to Tuskegee, to et cetera. This is a very, very old challenge. And kudos and pushing it forward. Really excited to see how it grows. Sorry for the pun.
No, I love it. I love the pun. In fact, I was saying to someone, they were like, are you going to have to change the name? Imagine that, Mark. We can't say the word racism in the title. Imagine that. Yeah. That's not what I've heard so far, but are you going to have to change the name? It's like a legitimate question. And I was like, we are not changing that name. That is too good of a name. I don't think we need marketing around that one.
No, that one is, do not touch that brand. Fantastic. Well, thank you so much for the conversation today. This was so interesting. I wish we had another hour. Thanks for listening to Neural Compass, the Jiminy podcast. If today's conversation sparked something for you, follow us at Instagram, YouTube, or LinkedIn, or explore more at jiminyhealth.com. At Jiminy, we're building the future of mental health care with effective, safe, and enabled continuous care. See you next time.